All right, good morning. How is everybody today? I know it's early for people like me from the West Coast. So I want to thank everyone for showing up here today. We have a very busy but informative day. We're going to have an incredible number of speakers, a lot of topics being covered today. So I'm really looking forward to it. I'm glad you can all come out. I'd like to give a big thank you to our sponsors. Please go and talk to the different manufacturing companies here today, the ones running clinical trials and the ones commercializing. It's your opportunity now to ask any questions that you may have. So great opportunity to meet face to face. Got a lot of stuff for the kids to play with. So kids, you don't have to listen to people like me talk. Go have some fun, right? Because otherwise you're going to hear lots of stuff that just bores the heck out of you. I want to tell you a couple little things about debra before we move on. debra America was founded in 1979. My name is Brett Copeland. I'm the executive director. And I have a 17-year-old with recessive dystrophic EB. Been around with debra for 17 years now. So the growth that we've had has been nothing short of amazing. 10 years ago, we wouldn't be able to hold something like this. And if you've been to our CARE conferences now, we have more than 800 people showing up to these events. So it's a great opportunity. If you've never been to a CARE conference, next year is going to be in Los Angeles. You should definitely do it. It is a great experience for those that have not been there. It's great. You can talk to a lot of other people who have been there, so I highly recommend it. If you ever need any help, that's what debra is really here for. We've got our nurse, Catherine Dornbrock, based out in Colorado. You can email her at nurse@debra. You can call her. I think it's 833-DEBRA-RN or something. But the key is to always go to the debra.org website. We have just a ton of information there, how-tos, how to get help, information, approved drugs, clinical trials going on. So one of the things that I've been doing, we've all heard about the Medicaid cuts coming down the line. I'm sure we've all heard this now. A lot of what I've been doing is actually being in Washington, D.C., talking with our elected officials about healthcare policies and making sure drugs are affordable and that they are getting reimbursed. I was able to meet with the head of CMS, or Medicaid and Medicare, Dr. Mehmet Oz, about 7 days ago. And for the first time, and I've met with several past administrators of CMS, and this was the first time that the head of CMS, the largest insurance provider in the world, right, insurance company in the world, say the following things. These new therapies that are transformational and are really helping patients, either curing or treating, they're very expensive. We all know that. So the CMS director says it's important to pay that high price now so that we can avoid paying 6 times that amount in healthcare utilization costs. It is the first time that someone who runs Medicaid has said such a thing. So he's not the guy that makes the policies about the cuts and everything else, but he is the one that executes on these plans. And so I've been enthused about that. We're talking about incentives for drug development, specifically in rare pediatric diseases. We're hoping to get the priority review voucher, which may not mean much to you, but to the folks who develop drugs, it means a lot. We hope to get it reauthorized in September, if not by the end of the year. It is bipartisan, so we have a lot of support for it, so thank goodness for that. And there's something called credentialing out-of-state physicians. So let's say you live in Missouri, but you have to come here for your care, for EB, right? In many cases, states won't pay the physicians. They don't credential them, they won't pay for them. So we have a piece of legislation that would require them to do it and make the process easier, from a paperwork perspective. It's called the Accelerating Kids Access to Care Act. Also very bipartisan support. We are hopeful to have it enacted into law either in September or by the end of the year. Now I'm going to say this. Here's the problem. We've gotten it in bills before, including the one big, beautiful bill, and then it got stripped out at the last minute because of Rand Paul, right, or someone other. So while I say we're very hopeful that we're going to be able to get these things into law, you never know until someone signs it. But until they do, I'll be going back and forth to DC to make sure that these policies are in place for our community. One of the other things that I'm trying to do right now in working with the CMS is creating what they call an 1115 exemption. So as a lot of you know, not all state Medicaids pay for bandages. Not all insurance companies pay for bandages. The 1115 exemption would allow states to create a program, what they call a medical demonstration program, that would allow them to pay for bandages and get it out. So we're trying to make a federal policy with that. I'm working with Dr. Oz in doing that. He is supportive of this concept. So that's great. But that doesn't mean that the states will do it. Because once we get the federal, then we have to go state to state to state to state. Some people have seen recently in California that there's no longer any EB bandages available. It's not because they won't reimburse. It's because they changed, for lack of a better terms, where they get the bandages. The CVS pharmacy no longer carries the bandages. So it's called the formulary. Trying to fix it. Yeah, it's going to be a long haul. All of this is a long haul. So when you play in politics, even though they're not patient and they see only tomorrow, we have to see 2 to 3 years down the line. And so what I can promise you is, Deborah, is there 10 years from now and 5 years from now to make sure that the healthcare policies are there for you. Again, so that's all I'm going to talk about. I know that makes Jenna very happy. It's 9:45 now. We have a packed schedule for you today. We will have a catered lunch. It's, where are we having it again? Chick-fil-A, right? So we got Chick-fil-A being brought in. And then we're going to about a 45-minute break for lunch. Then we're going to come back and have some more programming. And then we'll have a social hour where everyone can just hang out and please drink up all the drinks that we have. For the kids, both Cincinnati Children's Child Life brought some toys. We brought a lot of toys. If you don't have one of these toys at home, please take them home. I can't take it home, so, Play-Doh, the Magna-Tiles, take them. Let the kids have them. If you need anything from us, Jenna's in the back. I want to say thank you to Jenna for putting together a great agenda today and doing all the logistics. She's right back there, so a quick hand for Jenna, please. See, we got Debra board member Leslie Rader back there as well. So make sure you tell her I do a good job. It helps me. Anyway, without further ado, I also want to thank Cincinnati Children's Hospital for really pulling together a great lineup of speakers and being so involved. So thank you very much. I do appreciate it. So we're going to start off with eye care, which is very important. As we all know, how many blisters do we get in the eye? How many corneal abrasions will it take? So treating the eyes are incredibly important. So can I have, I'm not even going to, Dr. DeSomnu? I know that. Is he not here?
She has pre-recorded.
Oh, pre-recorded, great.
So, okay. Well, good morning, everyone. Thank you for coming. My name's Beth Mavis. I'm one of the EB nurse practitioners here at Cincinnati Children's Hospital. Introducing all our speakers today. Our first one is Dr. Enilami DeSomnu. Hopefully I said that correctly. And she is talking pre-recorded about EB eye care. So Dr. Enilami DeSomnu, she's a distinguished ophthalmologist who graduated summa cum laude from Kentucky State University. She earned her medical degree cum laude from Ohio State University College of Medicine. She completed her internship in ophthalmology residency at the Mayo Clinic, followed by a pediatric fellowship at Duke University, where she researched on pediatric glaucoma, and she earned multiple awards. In 2024, she furthered her education with a master's in public health from Harvard, receiving the Dr. Feng Ching Sung Memorial Award.
Good morning, everyone. My name is Enilami DeSomnu.
Currently, she serves as an associate professor at Cincinnati Children's Hospital. She directs medical student education in pediatric ophthalmology. She's actively involved in specialized care for EB patients and Charge syndrome patients. She's authored several scholarly works in her field, and her research focuses on pediatric eye disease, particularly ocular surface preservation in EB, retinopathy of prematurity, and intraocular pressure measurements in children. She enjoys traveling, cooking, reading, and loves spending time with her nephews, nieces, and godchildren.
Good morning, everyone. My name is Eniola Sumu, and I serve as the pediatric ophthalmologist for the EB Center here at Cincinnati Children's. For family reasons, I'm not able to be with you today. I will be discussing ophthalmic findings in EB. I have no financial disclosure. Today, we will discuss the ophthalmic findings, recommendations and treatments, briefly discuss new treatments and therapies, and provide a summary. Let's get started. A brief overview of anatomy. In this photograph, it demonstrates the lacrimal gland, which makes our tears, the corneal surface, breaking it down into the 3 levels or the 3 layers that make up our tears, and also demonstrates the eyelids showing the lashes and also the eyelids showing the meibomian glands, which we'll discuss. This cross-sectional photograph shows the layers of the cornea, in particular highlighting the epithelium and the Bowman's membrane, and also demonstrates the rest of the anterior segment of the eye. Let's jump in. Corneal abrasion is frequently the most common finding you will hear of with Epidermolysis bullosa. This occurs when the corneal epithelium is affected. This can also affect deeper layers of the cornea. You will hear of a corneal ulcer if a corneal abrasion becomes infected. One of the most prominent things about a corneal abrasion is the pain. They are incredibly painful. The cornea is densely packed with pain receptors and actually has 300 to 600 more pain receptors than the skin. So putting that in context, you can imagine you can feel a pinprick on your finger, how much more can be felt if there's a corneal abrasion. The healing in EB can be very variable and sometimes very slow, and also the presentation is very variable, with ranging from no symptoms at all. This color photograph demonstrates a large corneal abrasion, and you can see the edges of the epithelium superiorly where they're flipped over. Other things that you will see with a corneal abrasion outside of pain, which is the most frequent, light sensitivity, excessive blinking. Some patients will report a foreign body sensation. There will be tearing, inability to open the eyes, and in some of our younger patients and even our older, there will be changes in personality. In a few subset of patients, I've had parents tell me they've never had any symptoms that they've noted. However, the examination is consistent with recurrent or previous corneal abrasions. Causes of a corneal abrasion: dryness, blisters, erosions or poor wound healing, exposure, trauma, inflammation. Next, we'll talk about corneal scarring and pannus. So corneal scar results after a corneal abrasion or a corneal ulcer. Depending on the wound healing and how the collagen for the cornea is laid, you don't get that clear window into the cornea any longer, resulting in a scar. Corneal pannus also results from dryness, all of the above: previous blisters, ulcers, recurrent erosions, inflammation, and ocular surface irritation, and I will show photos of that. In this photograph, you can see a corneal scar that comes from inferiorly, but also involves the visual axis, because beneath that is where the pupil is. So in this patient, they are not able to see using this eye because the scar is blocking the visual axis. This color photograph demonstrates pannus. As you can see, all these blood vessels growing in superiorly onto the cornea. And you can imagine if those grow onto or into the visual axis, that also will distort vision. The findings are symblepharia, which are adhesions from the eyelid onto the ocular surface. Here you can see adhesions going from the eyelid, distorting the shape of the eyelid and going all the way up to the cornea and into the visual axis of the cornea. Other findings in EB are corneal astigmatism, and this is secondary to all the different changes that can happen to the ocular surface. So, people or individuals who do not have astigmatism, we think about their eyes like a perfect rounded sphere or soccer ball. And what happens is light rays come through, and then they can easily form a sharp image onto the cornea. However, if you have a high amount of astigmatism, your eyes shape more like an American football. And so when the light rays come in, they don't converge into one spot and you have multiple spots they converge into, thus resulting in a blurred image. As you can imagine, with the multiple changes that can happen to a surface with epidermolysis bullosa, corneal astigmatism is very high likelihood. And this photograph demonstrates the clarity one should have if there is no refractive error. The next one demonstrates if you've got a little bit of a spherical error. And the last three photos, or the last three rows, demonstrate what happens in the setting of astigmatism and how the images are blurred and distorted. Corneal astigmatism can result in amblyopia, and amblyopia is poor visual development. It is important that this is recognized and treated accordingly to prevent permanent vision loss. Other findings are meibomian gland disease and blepharitis. Blepharitis occurs when there is a buildup of material along the eyelashes, and this can then affect the eyelid and the anatomy of the eyelid and result in things like swollen eyelids, red eyelids. It also changes the microbiome of the eyelids, and that can result in increase or imbalance of bacteria along the eyelid, and that can result in the release of toxins, which can be inflammatory, also resulting in red eyes. Meibomian gland dysfunction occurs when the meibomian glands, which make the oil that is part of the tear film, are not functioning properly. So either they're completely gone, secondary to recurrent eyelid disease, which can be seen in epidermolysis bullosa, or the oils that are being produced are not adequate. That can result in styes and other ocular inflammation. This colored photograph demonstrates an eye with meibomian gland disease, and as you can see, instead of having oils, you can see this thick viscous material that is being expressed from the meibomian glands. Other eyelid changes that are seen in epidermolysis bullosa are trichiasis, entropion, and ectropion. Trichiasis is a misdirected eyelash or row of lashes. Entropion is when the entire eyelid or part of the eyelid is turned inwards, and an ectropion is when the eyelid or part of it is turned outwards. As you can imagine, in all of these scenarios, these will cause significant ocular surface discomfort and also visual function changes. And a trachytic eyelash will result in irritation and can result in corneal abrasions if it continues to affect a corneal epithelium, especially one in EB that is already fragile. An entropion would certainly turn it inwards, irritate the ocular surface, and could actually be worsened with resultant eye rubbing. And an ectropion, where it pulls the eyelid away from the eye, also would result in poor ocular surface. Our eyes are built for our eyelids to rub against, and so in a certain where the eyelid is not well opposed, you don't get that beautiful tear film that you normally would get, and then that will result in degradation in vision. Moving on to treatments. The way I think about treatments in big categories, and my biggest category for epidermolysis bullosa is prevention, prevention, prevention. And that takes many different sources in order for us to do that. The primary one being lubrication. Lubrication. Next would be environmental prevention, really understanding the environment. Do I live in a drier environment? Do I need a humidifier around the year, or do I only need it certain times of the year? For us in Ohio, in the winter, things get very dry, so a humidifier that time of the year would be helpful. Do I add an air purifier into that in that setting to make sure that the moisture that is being put into the room is clear? How do you balance using a humidifier in a very humid environment when you consider, the skin and the bandages, really being active about the environmental surveillance and understanding where you are, hydration, sleep, what goes internally makes a big difference, avoiding trauma as best as is possible, addressing whatever the triggers are, redirecting behaviors, addressing the environment. Systemic medications, also understanding what's going on in the habitat of the body. For example, diuretics will dry out the eyes. Antihistamines, which are often necessary to prevent coughing, sneezing, and eye allergies that a patient may have, also could lead to dryness. So anticipating if this medicine is going to result in this, how do we treat it? Eyelid disease. Warm compresses are very important, especially when treating meibomian gland disease. Lid scrubs can be used, however, they should be used with caution in EB so that they do not end up abrading the ocular surface or the eyelids. So when necessary, these have to be used judiciously. And then omega-3 fatty acids. There's some studies that demonstrate they may not be as effective as previously thought. However, they do provide other aspects that may be of benefit in EB. Now, talking about treatments as they pertain to specific findings we can have. Corneal abrasions. Whenever there's a corneal abrasion, lubrication is essential. In addition, it is important to treat with a topical ophthalmic antibiotic. So in my practice, I give my patients with epidermolysis bullosa a standing prescription so that if there is an abrasion, they can start treating with an antibiotic to decrease the risk of getting an infection while they are calling or reaching out in order to get seen. You always want to treat any eyelid disease that could lead to a corneal abrasion. Contact lenses are both a treatment and a prevention for corneal abrasions, and we will discuss this shortly in the future. And then the use of topical ophthalmic anti-inflammatory medicines, which we'll discuss in the future, which in the long term are good treatment or prevention for corneal abrasions. Lubrication, in general, the preference is to use preservative-free artificial tears. Artificial tears with preservatives, you imagine if you're doing your tears anywhere from 4 to 6 times a day, you're putting preservatives on the surface and those can build up and in the long run can lead to other things we do not want. So the preference is for preservative-free artificial tears, preservative-free ointments if you're using them frequently. Ointments generally will last longer on the ocular surface. However, those ointments can lead to a blurred vision because of their thickness. So balancing what is needed at what time. And also it's really important to talk about the administration of these medicines. As you can imagine, these are photos of my technicians. If you were putting an eye drop in a relatively cooperative adult, that can seem easy. However, most of our children really struggle with this, with closed eyes and just a fear of anything that comes close to their eyes. So let's take a step back and let's remember that as humans, it's very normal for us to always want to close our eyes when anything comes near it. So now we're trying to go against a natural reflex. And in a child who's already uncomfortable and in pain, trying to put something into that eye, telling them it's going to help get it better, but a child may not fully understand what is being communicated. So really the administration of these medicines is really key in order to make sure that you're lubricating and not causing more harm. Talking about anti-inflammatory medicines, the beauty of these is they decrease the inflammatory cascade, which then starts once you start getting abrasions, especially epidermolysis bullosa, and you can sort of enter into a vicious cycle. The mainstay are steroids. However, long-term use of steroids can result in other ophthalmic findings that are visually significant, such as glaucoma and cataracts. Given these, we've veered to start using non-steroidal anti-inflammatory medicines, which help modulate the inflammatory pathway. They're great because they can be used safely long term. They decrease abrasions in the long term because they're modulating and they're affecting that inflammation or inflammatory cycle or pathway. And they can also modulate the scarring, and so it can sometimes be very helpful when there's a corneal scar. They don't decrease the scarring to the extent that a steroid will, but they can be used in conjunction with a steroid when necessary and can, as I've said before, can be used. Contact lenses. Contact lenses are a great treatment and prevention for corneal abrasions. They're used in treatment when the pain is severe, as they provide that barrier and can help decrease the pain, but also help with the healing process, removing the ocular surface from other things that could continue to irritate it and lead to decreased healing. While contact lenses are a great tool for treatment and prevention, they need to be used carefully to prevent the real but low risk of getting a corneal ulcer. Contact lenses and how they're used in epidermolysis bullosa 24 hours a day, 7 days a week, need to be prescribed under the care of an ophthalmologist or an optometrist, and they need to be prescribed alongside with a topical antibiotic. It is important for any patient who uses these contacts to adhere to all the recommendations in order to prevent any complications which could then further compromise or complicate treatment of epidermolysis bullosa. Here on the right, one of my technicians is demonstrating a soft contact lens, which is what we think about when we think about contact lenses. These are great. They can be used 24/7. And in our practice, we put them in anywhere from 3 to no more than 4 weeks at a time with the use of a topical antibiotic, and we have the patients come in for placement and removal. A few families may be comfortable doing this at home, but we also recommend frequent check-ins with your local eye care provider. On the left of the screen is demonstrating a scleral contact lens, which we do not use routinely for epidermolysis bullosa patients. I do reserve these for use of patients with advanced ocular surface disease, because with the scleral contact lens, it creates a bowl, and there's that fluid interface that sits on top of the cornea. Thus, the surface can be bathed with fluid all the time. In addition, it can also help significantly improve vision. Scleral contact lenses typically are made of a hard material, and they are typically harder to place and to remove, and need to be carefully monitored to make sure they do not create other problems on the ocular surface. Moving on to new therapies. Already discussed scleral contact lenses. There are now new topical ophthalmic medications which can help reverse corneal scarring. Some of these have been described in other patients with ocular surface disease and how long-term they have modulated the cornea and reversed scarring. Another significant improvement is gene therapy. Vyjuvek has been used for skin epidermolysis bullosa and is currently being studied for ophthalmic use. It is currently approved for compassionate use in the United States, and thus is not yet available, but we are all looking forward to the results of the studies and to studying it further to knowing how it can be used for our patients in the long term. Recommendations and summary. Recommendations. An ophthalmic exam once a year is recommended in EB, with patients with RDEB and junctional needing an exam every 6 months or even more frequently, pending the ophthalmic findings. Active prevention and active surveillance for treatable and reversible vision loss is important, and a continued discussion with your ophthalmologist or local care provider about advancements in treatment should always be had. Contact lenses need to be in the right patient, right clinical context, right social environment, and with the right ophthalmic provider. Ophthalmic surgery needs to be individualized, and sometimes I consider it more of a last resort, making sure that we've exhausted other options if there's a visually significant change, because sometimes the resulting scarring post-surgery may be more exuberant than that was present pre-surgery. It's always important to consider the social and economic support every EB patient has. Thank you very much for your kind attention. An email address is provided below, and enjoy the rest of the meeting. Bye, everyone. Good morning, everyone. My name is Aniolani Dosumu, and I serve as the pediatric ophthalmologist for the EB Center here at Cincinnati. I have no financial.
Okay. So that was Dr. DeSomnu talking on eye care. If you have any questions about any of the information that you saw today, feel free to email her and she will get back with you. Our next speakers are Dr. Ruck and Dr. Bobby. So Dr. Ruck is a board-certified pediatric dermatologist, assistant professor at Cincinnati Children's. He's dedicated to the EB Center at Cincinnati Children's and practices part-time in private dental office in Cincinnati. Previously, he served in the National Health Service Corps, providing dental care to Eastern Band of Cherokee Indians in North Carolina and the Navajo Nation in Arizona. His clinical and research interests include dental materials, integrating new technologies into hospital dental programs, and pediatric hospital dentistry. Dr. Ruck is also a key leader in the New Smile, for New Smile, a company specializing in pediatric dental solutions. He enjoys all aspects of both pediatric and general dentistry. He resides in Cincinnati with his wife, Magdalena, daughter, Carolina, son, Winston, and 2 dogs, Waffles and maple syrup. Dr. Bobby, Dr. Thickershe is his formal professional name, but everyone knows him as Dr. Bobby, is a professor at Cincinnati Children's Hospital, serving in both the Division of Pediatric Dentistry and Orthodontics and in the Division of Bone Marrow Transplant and Immune Deficiency. He earned his Doctor of Dental Surgery from New York University and completed his pediatric dentistry training and master's degree at The Ohio State University. An Air Force veteran, he served as Chief of Pediatric Dentistry at Ramstein Air Force Base in Germany. Dr. Bobby is a diplomat of the American Board of Pediatric Dentistry and currently chairs the AAPD Committee on Sedation and Anesthesia, also serving as a parliamentarian on the AAPD Executive Committee. He's received multiple awards, including the AAPD Pediatric Dentist of the Year and the Merle Hunter Leadership Award. He's published extensively on dental disease, sedation, and oral health in medically complex populations, and he's been a dedicated member of the EB care team for over 12 years. And welcome, Dr. Bobby and Dr. Ruck.
We really hate those bios. The most important thing is I have a son, I'm married and have a son who's 23, almost 24.
And I have a 4-year-old and a 2-year-old and 2 dogs.
And I have 4 dogs.
Yeah.
Now, his dogs are more feral than my dogs. One of his dogs has a death wish, and literally...
Yeah. One of our dogs is in diapers full time because he's a wild guy. So he's...
But thank you for including us. Thank you for the opportunity to come talk. As Beth mentioned, I've been here just over 12 years, and I was looking back over my kind of logs, and in those 12 years, I've probably seen about 150 kids with EB in some manner, which, the numbers, I always remember, like, as I was walking in today, and I saw Miles, and I see these faces, and Lindsay, and so for me, it's always about the faces, and I think when we talk, we always talk about our EB patients by name because we know them. And I still go to, for us, really the resource is Dr. Tim Wright, who's on the debra medical board. He's done a lot of the research, a lot of the clinical, is my mic?
Testing.
Did they mute me?
Yeah, they must have muted you. Tim must have heard.
I think they were worried. Yeah. Can you all hear me?
There we go. Sorry.
There we go. Tim Wright, who does a lot of the research and a lot of the clinical recommendations as well. So how this works is Patrick and I split our time kind of taking care of EB kids. It's probably the most fulfilling part of our clinical practice lifetime. And we get to know not only the kids, but the families. So we will talk about teeth. And I think there's the clicker.
You want me to click through?
Yeah, that's good.
There we go.
So we're going to be short and sweet. One of the things that we tell all our families is having EB does not mean you will have bad teeth. There are ways to take care of this, but my little after phrase is you will have to work harder. Having EB does mean that you will have to work harder at maintaining oral health and teeth. And our job is to give you strategies on how to be able to do that. Oral health starts first day of life. This is, one of the changes over the past 12 years is initially we would see kids who were coming in symptomatic, having issues, tended to be older kids. It's been wonderful for us to see our younger kids, including the infants, and to start being able to give families strategies very early on to prevent dental disease. Before I formally retire, I have this guerrilla campaign that I want to conduct, which is if you walk around the hospital, all the pictures have everyone smiling and all these teeth. And I want to go around and I want to black out all the teeth. And I want to say, dentistry is important. But I'll do that right before, like the day before I decide to retire. But it is true that when you see someone, the smile is one of the first things that is a social cue. And we work very hard to preserve that smile as much as possible. So the diagnosis of EB in any of the forms is often overwhelming. It's multidisciplinary, and very often, and this is not unique to EB, it's in a lot of populations that have special health needs, teeth are deprioritized. Teeth kind of go down the list. Teeth are not a problem until they're a problem. And so our job is to make sure they're never a problem and that they don't limit any other aspects of life or medical therapies. It's very difficult to find a team, and not only where you have a dermatologist and a plastic surgeon, orthopedic surgeon, these qualified members, but also having a dentist who's comfortable, and then our, unsung heroes, anesthesia. We all need a very good, competent anesthesia team. Just an FYI, and Dr. Ruck and I fight this battle every day, it is less likely to cause blistering if the tube goes through the nose than if it goes through the mouth. So our anesthesia teams will often argue with us, and they will want the tube through the mouth. We almost guarantee that will cause blistering because the tube is rubbing on the tongue. The nasal mucosa is different from the oral mucosa, so we are less likely to get blistering. So we really try, in order to preserve kind of mucosal integrity, to have nasal tubes wherever we can. We are going to be resources for you. Beth, Nicole, all of them have our emails, our cell phones. If there's ever anything, any question, if you're in a region and you're not sure if there's someone there, you can reach out to us, and we are happy to look through our big book of former residents and practitioners to try to hook you up with a team. Next. Anticipatory guidance. So from a very young age, this Collis curve toothbrush many of you use, which is curved so that it does not rub on the gums, but still keeps the teeth clean. The ones on the bottom are Ultra Suave, which are very soft and very narrow brush, which can also be used. But brushing is very important, and EB is not a reason to not brush. Our job is to try to help you find the best toothbrush for your child. And I can't say this enough. We did a study, this was years ago, where we looked at 0 to 3-year-olds in our clinic, not EB, just 0 to 3-year-olds. And we found 20% of them had soda in their sippy cups. So this is like pouring battery acid on teeth. It just dissolves baby teeth away. So sugar sweetened beverages, and I think my next slide is the big message. You can hit that.
Oh, sorry.
Which is, whenever possible, avoid food as a reward. Because food as a reward is usually either a sugar sweetened beverage or a highly sugar substance that sticks on teeth. So if there's any way to avoid food as a reward, that is something that we really would encourage, because we've seen really significant dental decay and crowding. One of the other things that I'll say before I turn over to Dr. Ruck is we will assess kind of the opening, and as we palpate in the cheek, we can feel the tightness of the muscle. So many of you know that as the child grows, that tightness can move forward. And as that tightness moves forward, kids will get what's called a purse string mouth, which is their opening narrows. And that becomes much more difficult in early teens to get access to dental care. So one of the things that we look at is if we see this opening starting to really close significantly, we may recommend preventatively removing back molars to be able to allow you to keep teeth clean and really focus on the teeth up front. So that's something that we may say, but we would do this in conjunction with the EB team, because we want to make sure, particularly our feeding colleagues, that we are supporting you as well as the rest of the team.
All right, cool. Thanks, man. I can click.
Yeah.
I just again wanted to say thank you for coming, and thank you for letting us see you guys. I know when I first came here, Dr. Bobby trained me when I was here from 2014 to 2016. And then I went on some adventures to go live out west, and I've been back since 2020. And I still remember the first time I came into a room with an EB patient in it, a friend, and they said, well, "Where's Dr. Bobby? You're not Dr. Bobby." So one, thank you for letting me take care of you, to see you. I try to learn as much as I can from people like Dr. Bobby, from Tim Wright, from Dr. Cannon, who have been in the EB community for a really long time and trying to kind of keep our clinic moving forward as far as what we can offer treatments for EB friends. And one thing that I wanted to talk about this afternoon is what me and Lindsay were talking about on Wednesday, is what else can I do? You know, and Dr. Bobby said we brush, we try to watch our diet, we try to take care of our teeth. And as we get older, our opening and access to those areas can be really difficult. It's hard to do crowns or fillings or implants or dental extractions, and those treatments, like our ophthalmologist friend said, surgery can almost be as difficult as what's causing the reason for the surgery. So one thing that Lindsay and I were talking about, and she kind of inspired this part of my talk, is, well, what else can I do? You know, what else can we do outside of that? And so one thing I wanted to talk about, and Dr. Cannon talks about this a lot, is just some additional adjunctives that we can do. I do this. I'm kind of a big hippie when it comes to oral hygiene. I'm really into other like probiotics and things like that, and I'm hopefully going to bring some research into that as well as other things that we can do that aren't insanely hard to add to our oral hygiene regime, and going from there. So one thing that I looked at, and I was a big math nerd in school, and I don't know if you guys remember this from grade school, the order of operations. I was like Googling this because we are always talking about like, well, do I brush first? Do I floss first? Do I use my mouth rinse first? And the only thing I remember about this is, please excuse my dear Aunt Sally. It's like one of those things where that part is more, if you gave me a math problem, I probably couldn't solve it, but I could remember that part. And one thing that's really interesting is when we were kids, we always learned to, rinse, or brush your teeth, floss, and rinse. And now it's kind of backwards. And it's, if you're going to use a floss or water flosser or some type of device, you're going to do that first. Or if you have a mouth rinse, you're going to do that. And then you brush last. Well, why do we do that? Why are we recommending that now? And if you look at some of this research, it's not very popular research to look at people, group A brushing their teeth and rinsing their mouth, and group B not. You know, it's a hard thing to say, I want to do this research project where people don't rinse their mouth afterwards. So it's hard to find the data on this. But the reason why you don't rinse your mouth out after you brush, or you try to brush last, is it keeps the protective stuff in toothpaste, whether it's a fluoride toothpaste or a xylitol toothpaste, or those newer nanohydroxyapatite toothpaste. And we still recommend a fluoride toothpaste. And you want to use that last and then spit into your mouth. Spit into the sink. Don't spit into your mouth. That would be weird. Try not to rinse out afterwards. And the reason why is it's keeping those protective factors at least 30 minutes post-brushing. So the things that prevent cavities, and I do this myself. When I brushed my teeth this morning after I rinsed and flossed, I spit into the sink. And even for little kids, you know, I have, again, a 2-year-old and a 4-year-old, and I don't let them rinse their mouth out after they brush. And another great question is, well, what's your favorite toothpaste? And I actually do have an answer for that. Unless I like to use what's called stannous fluoride toothpaste. So that's the same thing as like your Colgate Total or your Crest Pro Health. I always joke because we're in Cincinnati, we have to support our P&G brands. You know, use your Swiffer, wash your clothes with Tide, don't eat Pringles because you'll get. But so I'm a Crest person, and there's a kids version. Or if you don't like mint, right? Mint's they make a strawberry flavor. It's a horrible name. It's like Crest Cavity Protection 2-in-1 Bacterial. It's a really long name, but it has stannous fluoride on the back of it. It's this really muscular tooth. Kind of like they probably were going after Mr. Clean, and they kind of came up with this tooth that was very muscular. But it has stannous fluoride in it, which has been proven. It's not a prescription strength toothpaste, but it's been proven to fight cavities better than your regular sodium monofluorophosphate, your regular over-the-counter toothpaste. So I recommend, again, if you're going to do, and we'll talk about oral rinses in a second, and if you're going to floss, a water flosser, regular floss, water pick, those kind of things are very popular right now, but always brush last. So another thing that I'm kind of big on, and Dr. Cannon kind of turned me onto this, I use these for everything I'm talking about. I took 2 of these this morning when I was driving in. Is we don't really say, if I had to tell you to take a probiotic for your stomach, they'd be like, yeah, okay, like, you know, antibiotics. When my daughter gets antibiotics, the pediatrician's like, hey, buy some probiotics because it can help with antibiotic-influenced diarrhea. Well, believe it or not, there's actually some pretty good research on dental probiotics. And these are pretty low-hanging things to do. For us, I take 2 of these every day, and these are just 2 different brands. The one Triscuits, I don't know what I just did. Okay. The one over here, there's not a pointer. Is there a little mouse, Dr. Bond?
There's this.
Whoa, this is like a lightsaber.
Yeah, careful. You may.
This one's nice for some of our friends with EB because it's a little dropper. It's in like sunflower oil. I'm from the South, oil. It's not the best tasting thing in the whole world. But if you look at, this is actually Dr. Cannon's research, Mark Cannon, a big EB proponent, is probiotics significantly reduce the cavity rate. Caries is just a fancy word for cavity rate of high caries prone kids without any bad side effects. So it wasn't statistically significant. Not only was it that, but it was very significant clinically with only 4 subjects out of 53 remaining caries prone. So it worked really well. And this is something you can do after you brush. Well, I do eat my breakfast, morning routine, and I actually just take some on my way to work. Or let's go out. Or once you're heading out somewhere or at nighttime, you can do this twice a day as well. There's not really a wrong way to do these. And it really can prevent cavities. And then another thing that Dr. Cannon and I read about this too is, you know, we call this prebiotics. We'll just call this the mouth rinse, right, before you brush. So there's a few different things you can utilize. You can use a xylitol-based mouth rinse, and xylitol it's a wood sugar alcohol that comes from trees, and it causes the bacteria that cause cavities, which is, believe it or not, there's certain types of bacteria that cause cavities. And all of us have, if we were to swab all of our mouths and do a science experiment, we'd all have different levels of bacteria in our mouth. Some of us would be really high. I'm sure we all have that friend that can eat whatever they want and they never get cavities. And they have another friend that I brush my teeth and I have a ton of fillings in my own mouth. But so this xylitol mouth rinse you can do before you brush. And then you also can get, and this is also in Dr. Bobby's world in the hematology oncology division, is a lot of our friends who get oral mucositis or things like that can use these xylitol moisturizing mouth sprays. You can use this throughout the day. And you can just put, or this moisturizing mouth gel. A lot of that research comes from our patients who have had head and neck radiation that have hyposalivation. But you can use this throughout the day, and it's going to provide a caries preventative strategy because that xylitol sits in your mouth and actually can disrupt the bacteria that's causing cavities. And you know, one thing that Dr. Bobby talked about, and in that eye thing, prevention, you know, the dentistry gets a lot harder and more difficult as that access gets smaller and smaller and smaller. And Dr. Bobby and I can both attest to our anesthesia friends going to sleep and us advocating for a nasal tube, getting x-rays, formulating a treatment plan, and a lot of it is carefully coordinated and collaborative. So if we can prevent as much oral disease as possible, and one thing that we're noticing too is we're seeing our friends younger and younger and younger, which is awesome. Like Dr. Bobby said, when I was a resident, a lot of times when we would see our friends in EB clinic, it would be, oh, we're having pain on this tooth. But now we get to encounter you so much earlier where we can have these preventative discussions as well. So these things can be used throughout the day, and they're very research supported for, one, just moisturizing your mouth and keeping, you know, a lot of us that take medications can pretend to get dry mouth. That's one of the most common side effects of medications that we take. So this is something that we can use daily as well as a pre-rinse. Oh, yeah. And then this is the big hippie. This is me going way. I used to work west of. Has anyone been to Asheville, North Carolina? It's a really big hippie town. So I kind of, and Dr. Cannon, who also, he lectured to us and he kind of blew my mind. He's a very nice man. He's retired now, but not really retired. I've noticed this when people are very passionate about something. I see Dr. like, you get retired, but I'm sure when Dr. Bobby retires, he's going to go do other things. He won't really be retired. But this is, and then this is a hard sell because I do this daily, but it's coconut oil. And you can get this, and it actually does feel really good in your mouth. This is for, does anyone know what Listerine is? Is everyone familiar? So what's Listerine? Listerine is just 4 essential oils that are diluted in alcohol. It's very burning. There's alcohol-free solutions, but all it is, the actual preventative effects that affect gingival health are the essential oils, peppermint oil, and so on and so forth. So there's really good research, and then this is a study that looked at coconut oil. And what it does is it helps in reducing bacteria inflammatory markers for periodontal disease. It's a safe alternative to chlorhexidine, which is kind of our gold standard for periodontal disease as far as an oral rinse. And I do this. It makes my gums feel velvety and amazing, so I love it. I mean, I'm not telling you guys anything I wouldn't put in my own mouth. It's kind of a hard sell, though, because it tastes like you're swishing with oil. But it does make your mouth feel really good. But this is something you can do it, you know, if just during the day or at nighttime or in the morning. I usually do it in the morning, and then I brush my teeth afterwards. So you can also pick and choose when you want to do this. And the last thing that we recommend is, this is in Australia, they call this tooth mousse. I call it tooth lotion. This is after we're brushing. So we finished all of our oral hygiene routine, and I usually recommend this at nighttime. This is a product that we give away in the dental clinic, so if you're ever interested, just feel free to ask. You can get this from your dentist as well. And it's a paste of calcium and phosphate. Your saliva naturally has calcium and phosphate in it. So what this does is it acts as a natural reservoir of calcium and phosphate around your teeth. 1, to help prevent dental disease, but 2, to act as a reservoir for remineralization. And there's no fluoride in these outside of your regular toothpaste. So you can use this at nighttime and just rub it on your teeth and leave it on. So we're using a fluoride toothpaste and then at night rubbing this all over your teeth, just like this person, and then you're just leaving it on overnight. So these are just all of our, and 20 minutes, I'm even over. Sorry, y'all. 20 minutes goes by really fast. But these are all of our oral hygiene adjuncts. And again, if you guys, I try to give my cell phone number to every parent. Dr. Bobby is also very similar as far as, if you guys have ever any questions, concerns, comments, Dr. Reamer always gets to us, so does Beth, as far as emailing us questions. If you need to come to the dental clinic, we're always a resource for you guys. We try to bend over backwards to make sure that one of us can be available to see y'all while you all are in town. So just let us know.
And like we'd said, our goal is also to find you someone close to home, someone that you can go to for a lot of the basics, and then we are part of the team when it's more advanced. So use us. We are happy to advocate for you wherever your home is. So thanks very much.
All right, thank you.
Great. Thank you, Dr. Bobby and Dr. Ruck. I was very nervous that you were going to fall off the stage at one point, so I'm glad you ended up backing up. Yes. All right, our next speakers today are Dr. Cornwall and Carrie Shotwell. So Dr. Cornwall is a professor of orthopedic surgery and developmental biology at Cincinnati Children's in UC. Dr. Cornwall specializes in hand and upper limb surgeries, clinical research, and expertise in EB, brachial plexus birth injury, pediatric trauma. He's been part of the EB Center since 2009 and serving as its surgical director for many years. He's a co-author of the Clinical Practice Guidelines for Hand Surgery and Therapy, has lectured widely on the topic. His research includes patient-reported outcomes, and he has a basic science lab focused on the molecular mechanism of muscle contractures. He's also exploring the biology of the hand contractures in EB through his scientific work. Carrie Shotwell is an experienced occupational therapist and coordinator in the Division of Occupational Therapy and Physical Therapy at Cincinnati Children's. She specializes in several multidisciplinary clinics, including rheumatology, CP, orthopedics, plastic surgery, and the EB Center. She received her doctorates in health sciences and a master in education, and she's been a member of the EB Center for 17 years. She also co-authored the Occupational Therapy for EB Clinical Practice Guidelines.
All right, thank you very much for the opportunity to be here today and to talk with you about hand care in EB, which has slides. There we go. Excellent. And this won't be as much a didactic lecture as it will be a discussion of the use of a compass rather than a roadmap in hand care for EB, focusing mostly on recessive dystrophic epidermolysis bullosa. Neither Carrie nor I have any relevant financial disclosures, but I must disclose that we have scant high-level evidence in hand care for EB. And in fact, in putting together the clinical practice guideline for hand surgery and hand therapy through debra UK, one of the conclusions was that we need better evidence. We do not have a roadmap or really good evidence to guide what we are doing in hand care, both non-surgically and surgically. And so instead, we need to use a compass. And the compass that I would like to propose to you today that we use is the 2-4 rule. Although we as hand care providers are taught to do things to hands, we need to make sure that we are doing things for patients. And the importance of doing things for patients comes, at least in my experience from EB, from a little bit of a story about my career, where I started as a pediatric hand surgeon at Cincinnati Children's Hospital and was working there for 5 years, taking care of nothing but children's hand problems, and I didn't see a single case of EB, although I had heard of it and I was a little bit frightened by it. And so I read about it, and there was one book that had one chapter about it, and it said you just take all the skin off the hands and you skin graft everything, and then you wrap it up in bandages with pins in there with an external fixator and big splints, and you end up with a hand that looks like this. And that seemed a little bit daunting to me, but fortunately, it was such a rare thing. It was a mythical beast in my mind because I never saw it. But then I moved to Cincinnati, and when I got to Cincinnati, indeed. And when I got here, Rich Aziz Khan, then the surgeon-in-chief, my boss here at Cincinnati Children's Hospital, said, I want a hand surgeon to come to EB Clinic. And I was looking around, and I was the only hand surgeon in the room, so I figured he must be talking about me. And that was all well and good, except that Cincinnati Children's is affiliated with UC, and my boss at the medical school, Peter Stern, a hand surgeon, was doing all the hand surgeries for kids with EB. So here I was with my two different bosses telling me to see the patients but not do the surgeries. Awkward. But what that meant is that for 2.5 years, I went to all the EB clinics and saw all of the EB patients, and I learned from all of you, rather than learning from Dr. Stern or other hand surgeons, although I did some surgeries with him just to make sure I knew the techniques. But what I learned was what the perspectives were from the patients. And I would see patients with hands like this who had had major hand releases like I had shown you, and it didn't really help much. And they said things like, it took forever for the hand to heal, the donor sites never healed, the contractures came back, it didn't help, I'm not having hand surgery again. In fact, some people didn't even want to talk to me, like I was the devil. And then I'd have patients with hands like this that said, I was doing fine until I lost my thumb, I want my life back, is there anything you can do for me? And so that brings up the 2-4 rule, where we can do a lot for patients without doing anything to them, and that's the non-surgical treatment. And then we can sometimes need to do things to the hands to do things for patients, and that's surgery. But then there's plenty that we can do to the hands without doing anything for patients, and that, to me, seems a bit nonsensical, right? So I'd like to start with the non-surgical treatment and pass it off to Carrie, who has a few slides about that.
Okay. So non-surgical treatment, beginning early on, we have parents asking us, should I start wrapping the hands? I'm worried my hands, that my big child's hands are going to start contracture. And we typically will say no, because that sensory development and that touch to the hands for the child to explore their environment is really, really important in their hand development. It's really important in developing their motor skills. Our hands are how we start to learn about the environment. Things first start going in our mouth, then we first start figuring out like, oh, then I can bang this toy on the table, and I can bang it in other hands, or maybe I can put it in something, and we start to learn how to problem solve, and we just continue to develop through there. So it's really, really important. We do recommend, like, if you really do want to wrap, to just maybe do it at nighttime while the child's sleeping, so that they can have their hands free to explore during the day. These are a couple of examples of wrapping. So we like the technique of just wrapping inside the web space in between the hands. And while we can't say that anything prevents or anything stops a contracture from developing, we are hoping that this maybe limits the progression of it. This is a video of somebody wrapping their hand. It is, we like to use the 1-inch Flexicon wrap. And you can see how they go around. Every time the bandage goes around the wrist, that's helping to hold what they've done through the fingers in place. And then this last part is really important here, the thumb. It's really important that the thumb isn't contracted and that you're going around that kind of bump at the base of your thumb so that it has free movement. If you go too tight, you can actually contribute to a contracture developing because you're locking the thumb in a certain place. These are actually post-op splints that I've done, but we have done a few that are pre-op as well. We're hoping that using a splint following surgery, or maybe perhaps before surgery, again, similar to the wrapping, helps to limit the progression and maybe limit contracture reforming again so quickly. We try to do as little as possible. So like these are two that are really just for the hands to help separate the thumb. The first picture shows Mepitel over the top of it, and that was actually a patient's idea. And it works great, and it, I think, just gets replaced, so it helps to keep the infection down. Sometimes I make something a little bit bigger like this, if it's needed, just depending on the particular child. And if anybody wants to take a look at this, I can leave it on the back table if you're curious about it.
Excellent. Thank you, Carrie. And so those are certainly some strategies that we think can help to slow the progression of contractures, but it certainly doesn't address the underlying biology of the contractures, which is actually not very well known. However, there are some clues, and there's the possibility that contractures can be at least slowed using losartan, which is a blood pressure medicine that also inhibits TGF-beta signaling, which is a molecular signaling pathway that is responsible for scarring or fibrosis. And it has been shown to prevent pseudosyndactyly, or fusion of digits, in a mouse model of recessive dystrophic EB. There have been several small studies with somewhat anecdotal subjective evidence that it can help in patients, but those patients all had fairly mild hand phenotypes, or hand contractures. More recently, the REFLECT trial was published in Lancet in 24 with 27 patients who completed a 9-month course of losartan, where there were improvements in many parameters of overall health, including some small measured improvements in hand contractures. These, again, were primarily fairly mild hand contractures, although there were some with more severe contractures, as you can see pointed out by the arrows, where there really wasn't an improvement in the hand contracture, and this was measuring the space between the thumb and index finger. Although, if you have a severe hand contracture and it's not getting worse, maybe that's actually an improvement, right? And so if we can even slow or even stop the progression of these contractures, that would be great. But the trick is, it's very difficult to predict how these contractures are going to progress. And so we've tried to answer that question in a collaborative investigation with Debra, where we, meaning the geneticists in Chile, genotyped 49 patients, so genetic testing to identify the specific mutations in the COL7A1 gene, and then determined the putative protein consequence. So what's going to happen to the collagen 7 protein with each of these mutations, categorized that as mild, moderate, and severe, and then we plotted the age that patients developed pseudosyndactyly or cocoon deformities to determine a slope of the progression of the contractures, and then correlated the two, and we found that the genotype, mild, moderate, or severe, was correlated with different speeds of progression of the contractures, where the higher the number, the worse the speed. So genetic testing could actually help predict the speed of contracture progression, at least in the Chilean population. We need to repeat this in other populations, but that could help us with the targeted treatments such as wrapping or even losartan treatment. But then there are folks who are going to need surgery, and so we need to move into the surgical category here. And what's difficult here is defining these boundaries, right? But I think these boundaries can be determined using 2 questions that I or others would ask patients, all of you. First, what do you want me to do for you? And that could be as simple as, I want to be able to eat a McDonald's cheeseburger without having to take it apart, right? And that was actually the very first hand surgery I did, was for a child who just didn't want to have to take their cheeseburger apart to eat it. So it became known as the cheeseburger procedure. And then the other question is, what do you not want me to do to you? And things like this would come up. Don't give me a non-healing wound from a skin graft donor site. Don't make me change my post-op dressing when I'm awake. And don't make me wear a splint forever so I can't use my hand. And so that really determined my early surgical strategy of focusing primarily on releasing the thumb, right? And then I was using skin grafts, but not from the abdomen or groin where you'd get non-healing wounds, but instead from the elbow, where you could protect it in a splint afterwards and it would heal nicely. And that was working pretty well with wrapping or splinting afterwards. And that would lead to improvements, which might be subtle measured, but could actually be transformative in your ability to use your hands. And you can see that I've been doing this for a long, long time. That's a BlackBerry. Phones used to have buttons. But then I had someone who wanted to learn how to drive with hands like this. And so we did the release. There's me, releasing it. There's a skin graft donor site up at the elbow, and everything went great in the thumb, except the elbow wound never healed. And she said, I really want the other side done, but I don't want you to use a skin graft. And so I reached out to Amy Ladd at Stanford, who has a lot of experience in this as well. And she said, oh, I don't use anything on there. Just put bandages on there and you just heal just fine. I was like, oh, that's a little bit much. So, is there anything kind of in between that we can do? And fortunately, a colleague of mine in Italy, Lorenzo Garignani, who, aside, is a diehard metalhead like me, and I only bring that up because of the Parkway Drive shirt out there. Rock on. He was using this product called Hylomatrix, which helps to promote skin healing in congenital syndactyly, so kids who are born with their fingers fused together, and it was working really well. And so I thought, hey, why don't we try that in EB? And sure enough, we did, and it worked really well with good early skin healing. I tried it again, it worked really well, and so and a benefit of that is with no skin graft donor site, then there's a much smaller dressing, much less impact. Again, trying not to do as much to patients. And it was working really quite well with good healing and good durable skin afterwards. And although there were some problems with excess moisture building up, there's a silicone sheet on it, and that could lead to some non-healing wounds. So unfortunately / fortunately, they stopped producing this or stopped selling it, and so I had to switch to a different product. Again, no financial relationship here, which is a similar, much more porous type of material that helps to promote skin healing, and that actually works just as well as the Hylomatrix. Over the last year and a half, I've been using that, and one of the really important outcomes is best summarized by one patient who had both. Whatever that was that used on my hand at the last surgery, I want that. It hurt way less, right? So there's some at least subjective evidence that this is a good product. But what really gets exciting is what about the gene therapy products that are out there? Can we use those in the hand surgery? And so we know about Vyjuvek, which is a gene therapy gel that improves wound healing. The trouble is it might improve wound healing too well and lead to a faster recurrence, with some anecdotal evidence from Paige Fox, who has taken over Amy Ladd's practice at Stanford. And it's not a long-term solution. And the problem in the hands is recurrence over time. It's not the early healing of the wound. Maybe the Ziva skin would be better because that's perhaps going to give us a more long-term correction of the gene in the region. But you can't do anything with that sheet that you get to put on there, and it's pretty tricky to contour it into the hand after the surgery. So that might not be what we need either. But what I know is that you can use a variety of different things to get the wound to heal, so you don't need a full thickness skin graft. So that probably belongs in a nonsensical category, where I also believe a whole hand release belongs. Now, there is a difference of opinion about that, and there are people that are very in favor of that, but I think that might be too much to do to the hand. But we have to keep in mind that these are not rigid barriers between these categories, and that they really vary from patient to patient, and we need to be attuned to that. There are folks who need more work done in the fingers and separating finger web spaces to be able to achieve their goals, and that belongs in a surgical category. And then there are patients with very, very severe deformities who don't need any surgery done for them because of their outstanding hand function. So as we think about what our surgical indications are, what we're going to do to the hands of our patients, we need to keep in mind what we're doing for them, and that needs to be defined by all of you, by our patients. Thank you. And as everyone has said, please reach out to us. We're easily contactable through the EB Center, or my email is just roger.cornwall@cchmc. I'm happy to take questions by email as well.
All right, our next presenter today is Dr. Kalyani Marate. She is a pediatric dermatologist and the division director of dermatology here at Cincinnati Children's Hospital. She also serves as a professor of dermatology and pediatrics at the University of Cincinnati. She's co-leads a monthly multidisciplinary vulvar dermatology clinic alongside pediatric gynecologist Dr. Christine Panizzi. Her academic interests span a wide range of pediatric dermatology conditions, including EB, vulvar disease, atopic dermatitis, psoriasis, genetic skin disorders, birthmarks, hemangiomas, drug eruptions, and infections in hospitalized patients. She is a recognized speaker on pediatric dermatology topics at both regional and national levels.
Thank
very
you.
much.
Thank you. I'm so delighted that we're doing this. Thank you, Debra of America, for collaborating with us on this conference. And thank you most of all to patients and families for coming. We're so delighted to have you here. And we're very excited to talk about, I want to talk about repurposed drugs. I'm going to talk about losartan. That's our baby right now. But first, I just wanted to acknowledge my wonderful mentor, Dr. Ann Lucky, who is here, and Jean Whalen, our nurse extraordinaire, who are back to see all of you all. And we're very happy to have them here as well. One other reminder, if you have not picked up an emergency kit, please stop by over there. We have made these kits essentially so that if you surprise have to go to a hospital that's not Cincinnati Children's, you will have the things that you need for doing some basic things like IV placement. All right, we're going to cover all of these. I'm going to talk fast. Start with losartan. Now, Dr. Cornwall already gave us a really, really nice overview for losartan for contractures. We know that particularly dystrophic EB patients have a lot of scar tissue, and we refer to this as fibrosis. And this can obviously lead to decreased function. We don't completely understand why this is happening. A lot of the research on this comes from things like excessive scarring, like keloids. And one of the things that people look at is this TGF-beta 1 to TGF-beta 3 ratio. Short version is patients that have recessive dystrophic EB have way higher TGF-beta 1 peptide levels, even in their blood. So this is throughout the entire body. But we think this is playing a big role in how scar tissue forms. So losartan has been used for, it's a drug that works on the kidney, and it's known to decrease the scarring and fibrosis in the kidney. So then people started thinking, well, where else can we apply this medication? And we think that this is all working through this TGF-beta 1, although I think there's still a lot more that we need to learn about this. And there's several papers that show that it helps with, on both in mice and in humans, that it seems to reduce the scarring and fibrosis, and it may even reduce joint stiffness in the longer term. Now, all of these these pictures are from various papers that have been published, and there is not very long-term follow-up on this because we really only started doing this in the last couple of years. So there will be more to come as time goes on. So these patients took losartan for 6 months. They had improved wound healing. And I'll just show you some more pictures. And this was only done over 6 months, so they did not see necessarily improvements in hand contractures, but things did not get worse. And there were definitely improvements in the wounds of the skin. So we obviously need longer term studies. We need to follow patients out farther. And this is the clinical trial that Dr. Cornwall was referring to. They started low and then increased the dose slowly. And at the end, they actually stopped, they lowered the dose slowly as well. And then they followed them after being off of the medication. So you can kind of see that while they were on the medication, they were doing a little bit better. And they still had some improvement even after being off of the medicine. The main side effect, this is a blood pressure medicine, so the main thing we have to look out for is blood pressure. So this is why we're checking blood pressures in clinic. We want to make sure that your blood pressure doesn't get too low. Here's another clinical picture of the patient, so before and then the while on losartan. But then even after being off of the losartan, they're doing better than the baseline. And then here are some closer up hand photos as well. So this is a very exciting thing for us where, we want to do everything we possibly can, right? We want to try novel things. We want to take medicines that are used for other conditions and see how they can apply to our EB population. The other interesting thing is this was a nice paper from 2023. It may even decrease the frequency of esophageal dilatations. So that is just another really, common issue that patients have, and we would love to be able to space these out, right? Less anesthesia, less having to come into the hospital. We would love that. There's another study that looked at, so trametinib also targets fibrosis. So they said, well, what if we take it and we combine it with losartan and we try it by itself? And so this is why I say this is a much more complicated thing than we really understand yet. Trametinib by itself actually made things worse. With the losartan, it didn't seem to make a huge difference. So trametinib's probably not a great option, even though it also works on fibrosis. So this isn't just like a very straightforward, oh, if it prevents scarring, it will work for EB. We do have to sort of look into these things much more closely. Up next, this was a little paper that came out where they took this medication that's used for another condition that works on blood vessel walls, and they took an antioxidant called N-acetylcysteine. It's used for Tylenol overdoses, and it works on the liver. It basically is a detoxifier. This may decrease this inflammatory marker called IL-6. So what we're learning about EB more and more is that this is not simply, well, we all know this is not simply a condition of the skin, but it's not simply a healing problem. This is an inflammation problem. So how are we targeting that inflammation? One, why are patients inflamed? How are they inflamed? And then how do we target that inflammation without making their immune system not work well, right? That's what we're kind of thinking about, is threading that needle. But this IL-6 is something that keeps coming up over and over again. So targeting that is going to be really helpful. Everybody knows that itch is a huge problem. It causes it's the most bothersome symptom for the majority of patients, even more than pain. And in this survey study that Dr. Lucky participated in, itch is more severe in patients that have more extensive EB. That makes sense. They have more wounds and are healing more. It's worsened by dry skin, by heat. So our increasing temperatures are probably not going to help, but this is probably why a lot of patients flare in the summer. And then most bothersome at bedtime, we think because there's no distractions and you sort of really focus on your itch and discomfort. So let's talk about some things that target itch. So this is dupilumab, or Dupixent is the brand name. This is a medicine that's approved for a lot of different conditions. For eczema, it's approved down to age 6 months. It was recently approved for chronic urticaria and bullous pemphigoid. It's a great medicine for a lot of, in our clinic we call it vitamin D, because we're like, they're deficient in vitamin D, just give them a Dupixent shot. It fixes a lot of things. But it surprisingly works really well for our patients with EB, and we think that it's working on that pathway that's producing itch. And what's so interesting is it's not only helping people's symptoms and making them feel better, but it seems to be helping their wounds, which, I mean, makes sense, right? If you're not itchy, if you're not traumatizing by scratching, then it allows things to heal more quickly. But that's what we're actually seeing in real life, which is amazing. So there were several case series, and now there's larger case series. And we have quite a few of our patients on this medicine now, and they're doing very well. And then this is another case series, so you can see sort of the before and afters of how much patients have improved. And I can tell you from our own patient population, we are seeing this in real life. All right, let's talk about aprepitant. Aprepitant is another medicine. This is another repurposed medicine. It was originally made for nausea due to chemotherapy, and it targets this signal called neurokinin, and I'm sure that our pain folks will talk about this a little bit more later. But it also helps with itch for some other conditions, and it's not every patient, but for a lot of patients. And the nice thing about this medicine is it has a really great side effect profile, and people tolerate it really nicely. This was actually a paper that was done here by our colleagues, and they looked at the aprepitant in both EB as well as in eczema patients. And it's interesting, it seems to work more in our older patient population. All right, next I'm going to talk a little bit about botulinum toxin, or the brand name is Botox, which we know is used for things like wrinkles and for excess sweating. But we have seen that it also helps with blistering on hands and feet for particularly our EB simplex patient population. And then it can also be used to treat anal sphincter spasm and fissures and allow those to heal. And we have some patients that have had that treatment and have done really nicely with it. So this is another treatment that we are taking from a different area and using for our patients. And when we do these injections, we do them under sedation because they are very uncomfortable. So we don't want people to be awake for this, but we do. It's about 25 injections per hand or per foot. But it really works very nicely, and it may be because it's decreasing sweating, and that's what's sort of driving the blistering. We don't really know, but it does seem to work well. All right, a couple of things that are for other stuff that we're using in our EB patients here. This is a foam that was actually recently approved for basically bad dandruff, and dandruff in a lot of different places. It's nice. We did one of the clinical trials here for eczema, and our patients really liked it. It was very easy to tolerate. And this is nice because it's a foam, and we know that a lot of our patients have scaly scalp, flaky scalp. They get skin, dead skin, kind of stuck to the hair, and it can be really inflamed. This is nice because it's not a steroid, and so it doesn't have the side effects of thinning the skin. So we could use it pretty liberally. And we've had patients that have really liked using it. And then we're doing a couple of compounded medications here that I think are pretty exciting. So other things that, we're trying to think outside the box and do novel things. We're working with our colleagues that make compounded medicines in our pharmacy and a pharmacist in Philadelphia. So topical tobramycin we now have here. And so people that have frequently had Pseudomonas infections have used a lot of gentamicin, and maybe the gentamycin's not working so well anymore. This is a different antibiotic that also treats Pseudomonas and can be used to treat anything that looks like Pseudomonas. Our patients always know when there's Pseudomonas growing. And then topical gabapentin, we have for several patients that they seem to really like. It's nice because it's more of a focal use. You use it when you need it, where you need it. So when things are really uncomfortable in a specific area. And then also some other compounded topicals for thickened hand and foot skin. So there are many things that we can try. So we're happy to talk with you. We're happy to innovate with you. And if there's new things that you're reading about that you're interested in trying to pursue, we would love to look into that with you, because we want to broaden the things that we can offer you. And that is our main goal, is getting you absolutely cutting edge stuff right hot off the presses. So we're delighted to be here. Thank you to everybody. Thank you, especially our EB team worked really hard with the Debra America team to put this together. And please email us with questions. We are happy to talk through any of your ideas.
Okay, our next speaker is Sarah Crawford. Her talk today is pre-recorded, so we'll get that started. But Sarah is a pediatric genetic counselor at Cincinnati Children's with expertise in EB, pediatric oncology, hemophilia, and general genetics. She earned her graduate degree from Emory University in Atlanta. She joined the EB team shortly after, beginning her role in 2023. Her work focuses on providing specialized genetic counseling and support for children and families affected by complex genetic disorders.
Hi everyone. I wish I could be with you all in person today, but it's an honor to be talking with you all. And thank you to the tech folks for helping me out so I could record this. My name is Sarah Crawford. I'm a genetic counselor working with the Cincinnati Children's Epidermolysis Bullosa team. I'm recording a small presentation today about genetics as it relates to EB. Before I begin, I want to share how grateful I am to the EB team and how lucky I feel to be able to work with folks with EB. So patients and families, you all are amazing and make my job so meaningful. So let's dive in. To go back to biology, our genetic code is stored in each of our billions of cells. So chromosomes are the structures within the cells that hold our genes. We have about 25,000 genes, each with its own specific instruction. And if we look further at our genes, we would see the letters of our DNA. So the body reads our genes like a book to make proteins that tell our bodies how to function and grow properly. So it's spelling changes or variants. Sometimes you'll hear the word mutations in a letter of the sequence of the DNA within a gene that can cause the gene not to work properly. So when this happens, the body cannot read the gene and make the protein. This is an example of a variant that I might see on a genetic testing report. We'll start with the gene itself. In this example, it is COL781, which encodes for the collagen 7 protein. And then the C dot, followed by those numbers and then the letters, refers to the position of the letter of the DNA. And so at position 6,127, there is a substitution for the DNA letter G to an A. And then in parentheses is a P dot. That refers to protein. And so basically, it's a switch of an amino acid in this case, and amino acids make up proteins. So GLY, or the GLY abbreviation you see at the beginning here, is changed at the 2043rd position to an arginine. So we know of a subset of genes that code for proteins that make up important components of our skin. I like this diagram from Debra because I think it gives a good visual. So it's looking at a diagram of the skin, and then next to it on the right, which subtype is caused when a specific gene is not working correctly in one of these layers. And so you'll see the four subtypes of EB being represented here, as well as the EB-related skin fragility disorders. Of the four subtypes of EB, these are the genes involved. So this just goes to show that there are many different genes involved in EB, and you can see some differences between the subtypes. So for example, for dystrophic, the gene associated with it is COL7A1. There's only one gene associated with it. This is different than a different subtype like simplex, where you can see several different genes associated. I thought it would be helpful to talk briefly about what I do and then why genetic testing is important. So what does a genetic counselor do? A genetic counselor coordinates appropriate genetic testing and performs consent. We take a pedigree, so this is a really important tool that we'll use in clinic, a big family tree just to get family history. We then perform a hereditary risk assessment based on the patient's clinical history as well as family history. And then when we get results, we counsel about these results and how they fit into a patient's current medical management. And we also assist in testing family members too. And all this to say, genetic counselors work in different areas, but for me, I'm lucky to work on the EB team, so I'm often, talking with these results with other EB team members and how those results fit into a patient's care. So why is genetic testing important? It informs the type of EB, which really helps guide our medical management and making sure we are providing the best care for our patients. Also, it helps us identify at-risk family members and helps us determine the inheritance pattern in the family. All of this to say as well, an additional benefit is it provides an answer for the family too. So that's a good transition to get into inheritance patterns. And I know this is kind of a busy diagram, so I'm going to break it down. So at the top, we can think of those two circles as cells, and all of our genes come in pairs, so we get one of each pair from each parent. In autosomal dominant inheritance, this means that only one non-working copy of the gene is needed in order to have the condition. So there's a pair of genes shown in each of these cells at the top. We can think of this as parent 1 and then parent 2, and then within each of the cells, the pair of genes. And so the red line on one of the genes on the left symbolizes that there is a mutation or variant in that gene that's causing it not to work properly. So one of the pairs of genes isn't working. And then below on the bottom 4, we see 4 possible reproductive outcomes. So essentially, there's a 50% chance that the parent on the left will pass on the copy of the gene that isn't working to a future generation. There's also a 50% chance that they will pass on the copy of the gene that is working to a future generation. So just showing here those potential outcomes, so 50% chance for any pregnancy where the reproductive outcome is an infected individual, and then 50% chance to have an unaffected individual. Just reviewing, autosomal dominant inheritance, 50-50 chance. We also often see a family history. The exception is that some individuals do have a brand new genetic change in them, and that is what causes their EB. And we actually don't see a family history, so it wasn't inherited from a parent. We can see that sometimes. The most common subtypes of EB that we see autosomal dominant inheritance at work in is simplex and dystrophic. Autosomal recessive inheritance, on the other hand, is typically we're in a scenario where both parents are what we call carriers for the condition. So same concept here, where at the top we have parent 1 and parent 2. Each parent has the pair of genes like before, and one of them in each cell has a red line, so a mutation or variant causing that copy of the gene not to work. And you can see that each parent has one copy that isn't working. In autosomal recessive inheritance, this is a concept known as being a carrier. So they don't have the condition themselves, but there's a chance to pass it on. So the outcomes are below. So if both parents pass on their working copy of the gene, a future child, there would be a 1 in 4, 25% chance that they would be unaffected, and this would be the outcome. There would also be a 50% chance that just one of the parents would pass on a non-working copy of the gene, and the other would pass on a working copy. They would be carriers. That would be a 50% chance. And then a 25% chance that both parents would actually pass on both non-working copies of the gene, and that individual would be affected and have EB. Just to review autosomal recessive inheritance, that's a 25% chance that each individual who is a carrier would pass on both non-working copies of the gene. A lot of times we don't actually see a family history in these cases, and it kind of hides in families. We can see this in all subtypes of EB. Some special considerations for genetics in EB. There's actually many considerations, but I wanted to highlight just a few today. So firstly, in dystrophic EB, it can actually be inherited in autosomal dominant or recessive patterns, depending on the genetic change. So in some families, someone with just one non-working copy of the gene might have the dominant form of dystrophic EB, and they could have a child that has 2 non-working copies, and that child would have a recessive form of EB. So thinking about, if that parent with the dominant form had a child with a reproductive partner that happened to be a carrier too, for dystrophic EB. So that's dependent on the specific genetic change as well, but that's a special consideration. Sometimes we can learn more from a specific genetic change about that subtype itself. So an example is for KRT14, that is a gene associated with EB simplex. And we can go a little bit further sometimes and say, okay, this specific genetic variant is more often seen in localized EB simplex than in severe EB simplex. So we could give that information to folks. And lastly, while we can learn a lot from specific genetic variants, like the subtypes and sometimes even more, we often say that genetics is not a crystal ball, and it's not going to predict every symptom a person may or may not experience. And we also know that family members with the very same genetic variant can often present differently. So I always like to say that as a caveat as well. But that's really all that I had. Thank you guys so much for your time today, and I hope that the rest of the day is great. Thank you. Bye.
Okay, so our last sessions of the morning are panels that we're breaking up into 2 locations. So the first one, if you are interested in staying for that, it is the expert panel for pain management in children with EB by Dr. Goldschneider and Dr. Ann Lynch-Jordan. So that would be here if you'd like to stay for that one. The other is a patient panel on sexuality and childbearing in EB. That is on D222. So if you go out the doors to the left, either the stairs or the elevators, it'll be up in room 22. So we'll give you a few minutes to break for that, depending on where you would like to stay.
Is Beth staying at this?
That's going to be more of an introduction.
I got it. Unless you want to. I think we do. Yeah. I would rather be Kingston. How did the move go? Nothing to get into. Right. Yes. And so that's where I'm like, I probably should. Appropriate way to ask it though. A better way to word it. Hello. Ooh, we're live. I'm going to take another 2 minutes to get settled, and then we'll start our expert panel on pain management in EB.
is going to do nothing.
Hello, everyone. Want to keep us kind of on schedule so we all have a chance to eat our lunch, which is a priority. So I'm going to go ahead and kick this off. I am Lisa Reamer. I am the pediatrician in the EB Center. I've been with the EB Center for a year, so really starting to get to know a lot of you much better, and it's been a really great time. I have the pleasure of facilitating this, we hope to be very informal session where we can talk about pain management, anxiety management, and kids with EB. So I have two long-standing EB Center providers, experienced EB providers. I will give you brief breakdowns, although most of you probably already know them. This is Dr. Ann Lynch Jordan. She's a clinical psychologist. She specializes in pediatric chronic pain. She's professor in the departments of pediatric and anesthesiology. Within her division, she leads the outpatient behavior pain management service. She's the primary pain psychologist in Pain Management Center, one of a team of psychologists in the Headache Center, and last but definitely not least, our psychologist in the EB Center with over 20 years experience. She has extensive experience in quality improvement, serves as the BMC QI outcomes lead. She's published her work in peer-reviewed journals and collaborated extensively on research projects in her career. So thank you, Anne, for being here. This guy, everybody knows, Dr. Ken Goldschneider. He's professor of clinical pediatrics and anesthesia here at Children's. He founded the pain management service at Cincinnati Children's and has been involved in caring for patients with EB for over 20 years in both the clinic and as his role as an anesthesiologist in the operating room. He's the lead author for the EB Pain and Itch evidence-based care guidelines and has been involved in developing new treatment for pain and itch in EB. So we welcome you all to this panel. I wanted to, like I said, have this be an interactive panel, but in order to get things moving a little bit, I wanted to pose a question to our two experts just to get the conversation started. I've noticed that bandage changes in these kids are a daily source of both pain and anxiety. And the combination of that makes the situation very difficult. I think it's hard to tell how much of the bandage change is pain and how much is anxiety. And so I wanted to open by just hearing perspectives on how can you kind of pull those apart? Can you pull those apart? Are those going to be hand in hand? And tips to help determine what's what. So who would like to go first?
All right. When Ann points at me, then the discussion's over. I guess I start. Thank you all for being here, and it's our pleasure and honor to be with you guys today. No, there's probably no pulling it apart, because if there was no pain, there'd be no anxiety. And if there was no anxiety, then the pain would be tolerable. And so round and round it goes, because that's the nature of anxiety. It's supposed to tell you when something's going on that it's not right and heighten your senses so that you can figure out what it is, how to avoid it, get through it, and so on. But when it's every blinking day, all it does is amplify what's already obvious, is that the dressing change hurts. So the two become wrapped together, and unfortunately they get wrapped together relatively early, because the toddlers, the babies and toddlers, may not be able to express exactly what they're thinking or feeling, but they're not stupid. They know that when something hurts, it hurts. And they know that when the crinkling of the dressing wrappers is heard, it means that they're going to have a dressing change, or the tub runs. They know that it's for them. That's not for who the tub tolls, it tolls for thee, and all that kind of thing. So they figure this out and can anticipate fairly quickly. So we have to take care of both, and it's preferable if we do as much as we can, as early as we can. And it even starts with stupid sounding things, like making sure that when you have a dressing change area, it's not under an HVAC blower. Because we may notice, oh, that's an annoying little breeze. If you have an open wound, that hurts. All right, so what's the right temperature of the room? Because again, we're going to be dressed. And even if we're like taking a shower and so we're not dressed, we can move quickly and get in and out. We can wrap ourselves in a towel or towel off really quickly and so on. So the ambient temperature could be unpleasant, but manageable. These are some of the things that actually become sort of, in a sense, primordial pain management techniques. Because if you attend to those things, you're starting off at a better place than if you hadn't paid attention to those things. And you guys all become experts in how to efficiently lay everything out, get things done quickly. Because again, dawdling through this, taking your time through it, just prolongs it. So there are things just mechanically, environmentally, logistically to be done. The medications, by now most of you have had some experience with some combination of medications, and you know that by and large we share the following frustration. The meds stink. All right, it'd be really lovely if they worked better than they do, but they don't. So the more we can do to make everything else go as well as possible, the better. And then the other thing is, we'll talk, I'll defer to some of the anxiety approaches, behavioral approaches to Dr. Lynch Jordan, but those become really important because it's only a mix of all of the above that has any prayer of being helpful. And starting all of that, whether it's distraction from a mobile for the babies, to playing some music, to letting the child have some say in what happens, and then knowing where to draw the line is kind of hard. Say, all right, no, you really can't decide about that. Yes, you still have to do this is hard. But knowing that, all right, if that waffling, that debating, that negotiating goes on for an hour, Well, that's an hour that they're laying there with their wounds exposed and getting more miserable, rather than say, okay, we're going to cut this discussion and get it done, because then you can go back to playing or whatever it was you were hoping to do before I started running the tub. Anyway, just some thoughts, because like I said, we can talk about the meds all day.
So I had to
and
defer
that's a
to
whole
Dr.
separate thing.
Goldschneider as my mentor to talk first, and he has now stolen all my thunder because I have little to say. No, just kidding.
It's payback for pointing to me.
Okay, fair. If besides the practical part of it being painful that we may or may not be able to control, I always try to emphasize, like, how can we keep patient and parent as absolutely just calm and routine as possible? And you're looking at me like, you're crazy, this can't happen. So there's two different things, like, how do we help the kids, and Dr. Goldschneider alluded to this, how do we help them be either distracted or relaxed? When they're little, you know, I'm not going to teach a child belly breathing, slow, deep breathing, although I have seen some very even-tempered little ones who actually will do that with me at 3 and 4. But that's a rarity, right? Most 3 and 4-year-olds are like, heck no, I don't want to do this. I don't want to lay still. This is horrible. So we're really looking at what is the best often distraction when they're little, because that's probably what's going to engage people the most. That is very nuanced to the particular patient. It can be anything from, I mean, obviously tablet and technology is great, but it's often used a lot. So you have to like up the ante. You may have to save a special show or a special toy or something that is uniquely distracting for bathing and bandaging. Otherwise it becomes routine. Well, they have tablet morning, noon, and night. If you're at my house, that's what it seems like. And so that becomes just a distraction, but not an ideal one. As they get a little bit older, and I think this is more of a mental strain on parents. I talk about brain games, singing songs, I Spy, the alphabet game. Truly, it's like anything that takes both parent and child away from what's going on. Now, right, that puts a huge burden on parent brains, and there's going to be some days where you're like, I do not have it in me to do this, and you do the best you can. As kids get older, we do teach them more of like relaxation techniques, like controlled breathing, because pain is a stress on the nervous system, heart rate goes up, breathing changes, they either hold their breath, they hyperventilate, they wail, all those things. It's just gonna get the anxiety, physical response to pain even higher. And so when they're a little bit older, we can teach them muscle relaxation, again, belly breathing, even sensory soothing things, like if some kids like to have fidgets or other squishies or things like that that just occupy their hands, either like little silky, good texture, that sort of thing. So for a child, that's what I work on with them. Sometimes it doesn't matter, right? Like you're at a stage where there's a 3-year-old who hates every minute of it. They scream from the start of laying out all the bandages to the end. And then I'm like, okay, if we can't do anything to make this child more comfortable, we're going to try and get the process done as quickly as possible, and we're going to try and keep parents as calm as possible. And that's where I'm like, freely give parents permission to put their earbuds in, turn their music on, and do what they need to stay calm, because even if your child is wailing, they are very aware of your body language, how upset you're getting. If you and your partner are arguing over, you hold the arm, no, you hold the arm, like you're doing it wrong, right? Like there's always one, and that just then ups the stress level for everybody. And so you're probably got a headache by the time you're done. This poor little person is, again, still wailing, and you and your partner aren't speaking to each other. And then I would agree with Dr. Goldschneider. Even if it's like 5 or 10 minutes of snuggle time, something that just helps everyone calm back down afterwards. Because, right, actually, I think the kids sometimes recover better, and parents are probably in still fight or flight mode, like, oh my gosh, we got through that. I still hate you for what you said. You know, like everyone's just so tense. And so if everyone could just, and that could be, again, cuddling, reading together, listening to a song, whatever. Again, that is very unique to the family. But I do think in the effort to try and get everything done, put everything away, be as efficient and get through it as possible, I think sometimes the 1 or 2 extra minutes of how do I keep myself calm? How do we recover from this? Sometimes you don't have time for it, but if you can, it's great because at least it feels like it ends something with everyone kind of back down to like a better place. So that's the anxiety piece, because we all know what's coming. And honestly, I have parents who are like, my stomach starts to hurt as I start getting all the stuff out. Like, I'm just as anticipating how bad this is going to be, just like the kids are. So we kind of talk about it for the whole system, not just the patient.
And just skipping back to the medications for a second, part of the issue with when to decide when to give, when not to give, is that most of the medicines are pretty decent for, think of it as static pain, pain that is there, but it is not, they are almost none of them good at blocking incoming pain signals of a new, that's newly generated. So if you've, I don't know, give me a great big cut on my arm, I'm not necessarily volunteering, but if that were to happen, and then you gave me a pain medication, it would help. But if you gave me that pain medication and then put a cut on my other arm, it wouldn't do a blessed thing, all right? The new cut would hurt because it's on top of whatever that new baseline is. Now, would it, I'm overstating, would it help take a little off? Yeah, probably. Would I be a little more relaxed because I was a little bit sedated? Sure. But none of the medicines that are available at home, because they're not anesthetics, are particularly good at relieving in-process pain, or pain that is newly in process, probably. But if something is hurting, yeah, they're not bad. All right. Same sort of issue does not apply to some of the medicines we use for anxiety, but the issue becomes long-term tolerance to those medicines, where they become less and less likely to work and work appropriately if you use them over and over and over again. And adding to that, that if you are using some of the pain medications, meaning some of the opioid pain medications, and you start adding some of the short-acting anxiety medications, which might work in that moment, you now have increased risks. And it's one thing to use these things in the hospital where you got like all these medical teams that can come running if there's an issue. It gets a little more dicey, at least early on. Now, there are those, of course, you get to be a bit older and you've been exposed to many, many things and you're tolerant to just about everything, and it becomes much harder to have a problem. But when we're talking about the little ones and they're just getting started and their bodies have not been exposed to much of those medicines, starting to combine those things can be a little dicey. And we've been, knocking wood here, very lucky we haven't had any major problems, but that's because we tend to be really careful and really somewhat hesitant sometimes in prescribing the combinations of things. And a lot of times, if there's any question, we'll often try something in the hospital just to see how things work. So that's part of the issues with the medications, that they're not fantastic at what we want them to do. And then there are, hit me.
I'm coming.
Well, don't cut me, but hit me with a question.
I think one thing you really do need to take into account are those parents who are single parents, and how are they, I was a single parent up until she was 13, and then I had another baby who had the disease. So I've had 2 children, plus I have the disease. And I remember, with my husband, I drew the line. I said, I am going to be in charge of this. Having more than one cook will spoil the broth, because you can't gauge each other's temperatures as far as pain control is concerned, because he's had some, but nothing like ours. And so I just thought, to keep the peace, I will do the dressings. And by then I was used to it. But anyway, when you're a single parent and you have a little one and you are doing everything for that child, who takes care of your emotional needs? Who can be there to go to bat for you? And I remember my oldest being in Children's Hospital. I'm from Columbus, so it would be Columbus Children's. And I remember, it was an emergency situation. They had my older daughter on morphine for dressing changes, and I lived at the hospital, and I also had a full-time job. But what occurred was I would go in to watch them, do dressing changes, the nurses. And I remember one time, and this is not to my credit, I got so upset I rose a hand as though I was going to hit my child. And because the stress was so built up and it was so solid, and I didn't want to hear her crying anymore. And then since that time, I cannot hear a tea kettle go off because it sounds like a child to me. And so, because when you're in the burn unit at Children's Hospital and you constantly hear the screaming, it's almost 24/7 because, nurses have to do what you were talking about and kind of plan things. But depending on your parental situation, it's going to vary, And another thing, too, we can't forget to talk about are teenagers. Sure, you may not lay them down on a table and do their dressing changes, but they have emotional needs that are just as raw, except in a different way. And, my daughters, they would go through staring, people would call them names. While it may not be dressing changes, everyday life hurt. And so you've got that to deal with. When you're dealing with EB, all systems are go. You don't have a choice, and it's not about you, it's about them. And that makes it harder because you have to be sacrificial in your way of dealing with life. And so, I know that the young are very precious, and, we do need to take care of them to the best of our ability. But as children get older, the needs change. And I don't think that's addressed enough. And I know that children who are teenagers, their needs are hardly discussed at all. And so I guess I'd appreciate hearing more about that kind of thing too.
Well, hence my role in EB clinic, just as you described. I probably spend more time with the adolescents than the littles because even if they have mental health services at home, they don't particularly have a, health-oriented psychologist who understands, like you said, all the daily ins and outs. I will say from a pain or bandaging or parenting perspective, it seems like by adolescence, one of two things happen. Either the parent and teen have sort of found a rhythm, whether it's sarcasm, they each have their own distractions, they have a method for getting through things, or we have a small subgroup of people who are medically traumatized, who have severe anxiety that has built over the years and is just highly distressing. And I think some of that, like you said, there's different family cultures, there's different personalities and temperaments. Pain is more unpleasant to certain people than others. People are more reactive. So I think that it's not like it gets easier. I think some people, by the time they're adolescents, have, at least from the pain standpoint, some coping skills. But we talk a lot about, as you were describing, more of the emotional pains of having a maybe different, or they have to adapt that what would be expected development in terms of friendships or driving. Are they going to go to college? Is graduation from high school the end? I wish I could have been in the romantic relationship sexuality section, because that's another issue for our older adolescents and young adults too. So I completely understand what you're saying, and also that each family culture is different. And so it's a little bit, when I was telling Dr. Reamer, I'm like, I feel like a fraud because I can say some generalities about things that I know to help with pain and anxiety, but right, it gets translated very differently from one family to the next as to what works or doesn't work, or the situation. So when I come in, I just try to listen and offer advice and problem solve together, and sometimes we all throw up our hands together. But with the adolescents, I meet with them more one-on-one, so they have that opportunity to be able to say, like, I hate mom at times because she's both my mom, still doing dressing changes, and and that's what we've hoped to create now with the psychologist in clinic, so that there is that ability to have those kind of raw conversations safely. And I ask about suicidal ideation, substance use, all the stuff that teenage worlds might do to socialize, cope with pain, cope with anxiety. So we try to address some of that. Probably not nearly enough, but we try.
Oh, absolutely. Yeah, no, the conversation today started with younger kids, because that's sort of how the session was titled, but we had to get started somewhere, so we started sort of where life begins, early. But without question, the teenagers run into some completely new things, because they are compounded not just by the cumulative effects of everything that's come before in their lives, but all the new things that happen socially. And not just sexually, but just generally socially, intellectually, drives for independence, which may not go the way, well, that won't go the way necessarily that they hoped, or that you as parents would hope, but maybe they will, and you don't know, and so there's all this uncertainty. And yeah, the teenagers go through some really rough times. Part of the emphasis in younger age is that by the time they become teenagers, if the patterns are set so that they are just freaking miserable with every interaction with their parents, or with the medical community, or with their medical condition, then that adds to everything else that you correctly are identifying as being horrible stressors for them. And so if we can set off on an earlier course to, at least, if we can't make all the pain go away, which at this point we can't, if we can make the experience of the pain a little bit better younger, by the time they get to be teenagers, they'll have a little bit less to deal with. At least that's our hope. But no, you're entirely correct. The teenagers, just as they are without EB, are their own species. There's that 10, 12-year period where I don't always know where they go. They generally come back, but but it's a really dynamic change and poses tremendous challenges.
Oh, sorry.
Very young child. Oh, I'm sorry. When you have a very young child, they will mirror their parents' emotions.
Mm-hmm.
So sometimes the dressing change may not, while of course it is dreadfully painful, the response to the changing of the dressing itself could be worsened if the parent is struggling, if the parent is, things aren't going well. However, in the personal life of the parent, And so the child will pick up on the parent's emotions, and that will feed into dressing changes, being more painful psychologically.
Oh yeah, I mean it's a family affair, to borrow a phrase. So no, you're right. The interaction is really, really important and affects everybody in the room. Sometimes people outside the room. Yeah. And we welcome comments as well as questions. So you guys all have experiences.
To build
you have
on,
a few.
To build on that, I've been actually fairly vocal lately to whoever will listen to me at Children's about the fact that they do such a wonderful job with the children, but children specializes in these chronic care conditions, not just EB. And there's just this big missing piece that they don't have something for the parents. And I feel like it's a blind spot because, as you're saying, if we're stressed, we're not just stressed about the bandage change. There might be, we're running a household, right, simultaneously, and there's all sorts of stressors, and we're supposed to be there, and we're human. And certainly people can go and look for outside therapy, but this is a very unique situation, especially as your child ages. I have a 27-year-old, and you want to continue to be there for them, but it's year after year after year. I don't want to scare off the parents of babies because you're in the best place you could be coming here, and you're going to get incredible care and be surrounded by amazing people. But I feel like probably especially the parents who've been in it for the long run, that there really is no resource. Palliative care found someone not associated with children's, basically a cancer group for me, and they kind of were like, we don't have anything, which is odd. And I'm just saying that, not that the EB Center, they have enough going on to form it on their own, but it's just something in general that I've noticed is missing at Children's for the parents, because we're constantly supposed to pull from this deep well of strength to constantly be there. And sometimes we get tired, and sometimes we're stressed for other reasons. So it's not pain management's job to do that, but it's just a common, and you've been addressing it a couple of times here, and it's a very valid point, because the parents are such an important piece, and you want to make sure that their needs are fed also. And that might just be sitting in a group of people, not just EB, but parents of chronic care children, and just talking about how difficult it is. And hey, what are some of the things that are good? And where have you found strength? It's just something that I'm glad you brought up, because it's like a missing piece, and looking at the anxiety of a child and the pain of the child, because it does reflect what that parent is, how the parent's acting. So
I think that's even more relevant as I'm thinking about it, because as the patients get older, right, I'm kicking the parents out of the room to give the adolescents and young adults time one-on-one with me. But that means now the parents aren't even in the room to talk about, to your point, right, I would say he's 27. He needs to have an appointment by himself, but then there's no parent loop around then, especially with an older adolescent or young adult. So your point is spot on.
Yeah.
And it was really kind of sad because I think maybe 6 of us showed up. And I don't know if it was a regional thing, and I don't remember like if there was somebody who was leading it. But I went to this support group, and the kids that were there, all of them were in wheelchairs. All of them, you could just look at them and know they had the recessive form. They were bandaged from the head to the toe. And then you've got my daughter who's running down the hall because she doesn't have it as bad. And I was sitting there during that meeting feeling guilty because my child wasn't in a wheelchair and all strung up in bandages and all that kind of thing. So, I was trying to help myself and my husband, we were trying to, get some support for ourselves, but all the people there could address was their child's pain and excuse me how bad it all was and everything. So in a sense, that support group turned into being a complaint group. I mean, I felt bad for the people, but at the same time, they complained the whole time, and there wasn't any advice given. There wasn't anything that you could shoot for and know that, yes, I can use this to help my situation. And I think it was really sad. It was supposed to be for the whole state of Ohio, and only 6, 7 people show, families, show. I don't even know if there is one.
Well, could I ask, based on what you were just saying, a couple things. One is that such groups really should be moderated in some way to keep sort of things going in a positive way that's helpful to everybody, so that you don't have one person monopolizing, or you have things just a complaint session as opposed to problem solving. And a certain amount of complaining is okay, because you're, as long as you're in a safe area where everyone says, you know what, we're in this together and this sometimes really sucks. But also to say, hey, who got to the baseball game the other day? Or can you tell me how you and your kid got out to do X, Y, or Z? So certainly the structure of such group would have to be carefully done so that it benefits everybody who comes, because everyone deserves the support, because nobody walks in each other's shoes. We all have different needs. All right. The other is just show of hands, just for a non-scientific question. Who would find an online support group, like a Zoom meeting format, helpful, with the opposite choice being having to meet in person? A couple folks. Okay. The reason I'm asking is sometimes you run into exactly the problem that you described, where with EB, even if you add all the subforms in, is not particularly common. So having a meeting on a particular day, on a particular time, cross-section that with the fact that not that many people have EB, means that you may only have 6 people show up. But if we were to do it online, where people across the country could participate, we might get a bigger group, and so you get more input as to how things are going, how people problem shoot different issues, that kind of thing. So that's why I was asking, so thank you for that. But you also brought up a really important point, which I'm gonna bounce back to the folks with little ones, is that you can't know exactly how things are gonna go based on other people's experiences. Because as your daughters had an EB, they had challenges in a certain way that, as you observed, other kids with EB, because it's not all the same, had different things. I remember meeting a young man. I was in the Netherlands or something for one of the big meetings right after our paper came out in 2014 or so. And we were chatting and asked about bathing, because that, of course, comes up all the time. You can't go to an EB meeting without talking about bathing and dressing changes. And he said he just took a shower. Well, I had spoken with several folks, and taking a shower with EB was like, oh my God, how could you possibly do that? Because the water's pounding on you, and it's regular water. It's not salt. It's not oatmeal bath, any of those additives. It's just regular tap water streaming down on me. There's no way I could do that. And that's how he did it. He goes, I get clean, I get in, I get out, and it works for me. Well, that opened my eyes to say, well, wait a minute. Baths don't have to be baths. Baths could be showers, depending on the person, which then leads me to, sort of kept this was now 11 years ago or so, kind of keeping an eye on what do people do, and it is all over the place. So don't assume that when your kids are little and the diagnosis is EB, exactly what's going to happen, because sometimes things change and the kids go, yeah, you know what? I don't like the fact that it takes 3 hours. The shower isn't a lot of fun, but I can get in and out, and you can throw these dressings on me, or we can throw them on together and get it over with in an hour and a half. And that's worth it to me. That gets to be some of the older kids where they can decide. But I'm just throwing it out there that don't make any assumptions, because each of the kids is unique, despite even if they have RDEB or any of the other particular variants. Each of the kids is going to be different, so their pain needs is going to be totally different, and how they want to approach doing one thing or another is going to be totally different. So just for what that's worth.
Thank you. Thank you, Dr. Goldschneider and Dr. Lynch-Jordan. The food is here. I would love to be able to continue this conversation.
But we will not stand in your way.
Unfortunately, we've run out of time. Thank you for that amazing idea. We will run with it and go eat. We'll reconvene at 12:45. 12:45.
Thank you, guys.